Dr. Mousavian, hi. Can you hear us?
Yes.
Okay, we want to start the session. Thank you so much. Yes.
Recording in progress.
Good evening, everybody around the country. I hope you have enjoyed your holiday, which is Friday in Iran. This explanation is for Dr. Walcher. And good afternoon to our European friends, especially Dr. Walcher from Europe, from Germany, and our friends and colleagues and professors from South and North of America, Dr. Lew Schon and Dr. Bastias. Now we launched the last day of the first biennial POTA meeting with foot and ankle trauma session, about 2 hours. This program is scientific basically, but when we are able to get together with our friends around the country, around the world, and we can hope joy and peace for each other, let's express our sympathy for Ukrainian people and citizens. I hope peace for them either. Let's get started very quickly with first speaker, Dr. Ebrahimpour, Professor of Orthopedic Surgery and Chief of Department in Bahaeddini Medical University. His great talk will be about post-traumatic fracture, when and how to fix it. Dr. Ebrahimpour, please.
Thank you, Alireza, for giving this chance to me. And now I have to go to share my, sorry. Good evening, everybody from all over the world. In Iran, I will have a short talk about posterior malleolar fracture, when and how to fix it. In memory of Professor Ulrich Holz, the great man who we lost him last year, and a great man who did great to POTA. And I had a chance to meet him last time in 2019 in DKU with Professor Romans and Hamid. The term of malleolar posterior introduced in 1911 by de Sotte. And as you know, this fracture occurs in up to 40% of 50% of all malleolar fractures. And for me, posterior malleolar fractures is something like volar Barton fracture. I compare it always in my mind, and I have my discipline to this fracture is the same as volar Barton. As you know, anatomic reduction of articular surface and fibular notch is essential for ankle stability and functional outcomes. CT scan is very important, three-dimensional, for classification and evaluation of the character of this size and displacement and location of the fragment. I'm not struggled myself with this classification. I usually pay attention to these characters. Well-known Haraguchi classification based on angle between bimalleolar fractures, and as you see, the type 1 is a very big triangular fragment involving the insura, and the type 2, the posterior malleolar fragment comes from this posterolateral to medial and even anterior of the medial malleolus, and the third one is a ring fracture, and usually it is comminuted or small or big. Barton's classification is also very useful, and as you see in type 1, it is an extra-insural fracture. It is based on fibular notch injury, and the type 2 is a small fragment, less than 50% of the insura, and this type 3, again, the same as you see the posterolateral coming to the posteromedial, and type 4 is the same as Haraguchi type 1, and these days they are talking about type 5, about irregular osteoporotic fracture. When to fix it? First of all, non-operative treatment. It is usually only indicated for isolated fractures without syndesmotic instability, and the operative therapy for several decades, we have this classic definition, critical size of surgical fixation for more than 25 to 53% of the articular surface, or displacement of more than 2 millimeter on lateral radiograph. But these days we are talking about 3D anatomy, and it is indicated when it involves the fracture, involves the insura, or the presence of intercalary fragment, plafond impaction, which is very important, and syndesmotic instability. How to fix it? Let's talk about surgical approach and the implant of choice. The approach is based on the location of the fragments. Usually posterolateral approach. I prefer to put the patient on lateral decubitus, but the patient can be on prone position also. And the longitudinal skin is made between the anterior part of the Achilles tendon and the posterior part of the fibula. And then after protecting the strural nerve and going deeper, the ideal approach will be with pronal tendons and FHL. As you see in this posterolateral approach, we can go anteriorly to see to expose the fibula when the fibula especially is fractured, and we can fix the fibula from lateral side by this plate, or my preferred location is the posterior part of the fibula, especially in elderly patients in osteoporosis, and less irritating the skin. As you see, when you want to fix the fibula, the incision should go furthermore anteriorly. But when the purpose is only the lateral, the posterior malleole, we can go a little bit posteriorly to the incision. And again, as you see in this video, we can approach fibula very, very simply between the skin and the anterior part of the peroneals without disturbing these peroneals. And as I mentioned before, the plate can be, the position of the plate can be a lateral part of the fibula or the posterior part of the fibula. Now we are approaching to fibula. And how to fix it? We can use, sorry, it is opposite. This is the transverse part of this plate. Distal radius place is over the posterior malleole, and just buttressing the plate something helps to put the displaced fragment in the proper position, as we will see in the C-arm later. This is an example. And for this fracture, as you see, we have an impaction in the middle of this. This impaction should be addressed very well. And this is another example. As you see, the plate is, the fibula plate is on the posterior part of the fibula. And from here, between FHL and peroneals, the posterior malleus is addressed very, very well. And this is the final result after fixing with this. And as you see here, then we will. sometimes we have to go to posteromedial side. And this is a modified posteromedial approach, in which the patient should be positioned in supine position. And we approach the fragment between neurovascular bundle and FHL is very simple, because if anterior ATFL is also injured, as patient is in supine position, we can address that injury also very simply. I had sometimes I had some complications using these plates, and sometimes the FHL entraps between the bone and the plate, and you see the check rein deformity or FHL entrapment, which I had once or twice, and I had to remove after union, remove the plate and release the FHL. This is another example using 1/3 tubular plate and also screws and washer for posterior malleol. As low profile, as better the result. And here we are using this cannulated screw for type 1 Haraguchi. Sometimes when the case is old, it comes later, and the posterior malleol contracts, and approaching this fracture is sometimes very demanding. I mean that it's difficult. In this case, as it was old and the patient was diabetic and so many problems, reducing the joint was very difficult, and I had to put a pin from calcaneus to talus to tibia just to maintain the reduction first, then fixing the posterior malleol. This is algorithm for Haraguchi type 1 or 2 and Bartonich 1 to 4. A posterolateral approach is the choice for Haraguchi 1. As you see, percutaneous posterolateral approach can be used, but in Haraguchi type T and Bartonich 1 2, the classic approach with posterolateral. And for fixing when the fibula is also fractured, it depends even the fibula fracture is complex or simple. We can use this subcutaneous window lateral, this fixing biologically, or doing an open reduction and internal fixation of fibula. But in Haraguchi type 2 or 3, as you see, posteromedial approach is better. And as patient, as mentioned before, it will be in supine position. When the fragment of ATFL is involved, the posteromedial approach can be easily used because patient is in supine position. Then the lateral fibula approach will be so simple. But when it is not, always we can use classic posteromedial approach, in which the patient will be in prone position or supine, depends on the approach. At the end, I have to mention that the risk factors for poor outcomes still are the size of the fragment, more than 2.5%. But if it is approached very well, and we could obtain good reduction and good fixation, it will be solved. Bartonich type 3 or displacement more than 2 millimeter. Articular step off is not a good thing for patient, especially when it is more than 2 millimeter, and tibio-talar subluxation and fibula malreduction into this insurer. Thank you very much for your attention.
Thank you very much, Dr. Ebrahimpour. Very great talk, and we have lots of questions, but as you know, we have run out of time. So let's go to another speaker, Dr. Lew Schon, Professor of Orthopedic Surgery, Foot and Ankle Surgeon at Johns Hopkins Medical University and NYU in Baltimore. He is professor in Mercy Hospital with his new grade team, more than 30 years experience in foot and ankle surgery. Dr. Schon, full of energy and love, as a real mentor always for me and for all the people that love him. He joined us from Baltimore. He's so busy, I know that, but he accepted very kindly our invitation. And it's good to know that he sent his talk about 3 a.m. And he started his operation at 6 a.m. So maybe 2 hours of sleep for him is enough. Dr. Schon, thank you for coming and joining us. Do you want to talk, or we can start the presentation?
Hi, I'm Lew Schon from the USA, and it's an honor to be here at the Persian Orthopedic Trauma Association, speaking on foot and ankle injuries. I'm invited by my dear friend, Ali Mousavian, and I am joining many of my associates from around the world here at this esteemed conference. First talk I'd like to give you is on syndesmotic injuries. My disclosures are here. Here I am with my mask, behaving appropriately for the COVID. And here is my dear friend, Ali, and Dr. Walcher as well, when Ali was visiting me in Union Memorial Hospital in Baltimore, Maryland. Right now, I'm at Institute of Foot and Ankle Reconstruction at Mercy Hospital, 3 miles away, but I'm also at NYU Langone in New York. Here are my partners there. And still maintain my appointment at Hopkins as professor of orthopedics there with my good friends, Jim Fickey. Here's my group at Mercy Hospital. Again, my dear friend Ali and his wife joined us, and we had a great time with them here in Baltimore. First, I'll talk about the anatomy. So the syndesmosis is a fibrous articulation between the tibia and fibula. There are 5 key structures: the interosseous membrane, the interosseous ligament, the anterior tibiofibular ligament, the posterior tibiofibular ligament, and the interosseous tibiofibular ligament. Sectioning has been done to see what contributes to syndesmotic instability. Well, the anterior tibiofibular ligament does about 35%, and the posterior tibiofibular ligament does about 40%. The interosseous ligament and the interosseous membrane also contribute, but less so. Injury to 2 of the 3 results in syndesmotic instability. Hi, I'm Lew Schon from the USA, and it's an honor to be here at the Persian Orthopedic Trauma Association, speaking on foot and ankle injuries. I'm invited by my dear friend, Ali Mousavian, and I am joining many of my associates from around the world here at this esteemed conference. First talk I'd like to give you is on syndesmotic injuries. My disclosures are here. Here I am with my mask, behaving appropriately for the COVID. And here is my dear friend, Ali, and Dr. Walcher as well, when Ali was visiting me in Union Memorial Hospital in Baltimore, Maryland. Right now, I'm at Institute of Foot and Ankle Reconstruction at Mercy Hospital, 3 miles away, but I'm also at NYU Langone in New York. Here are my partners there. And still maintain my appointment at Hopkins as professor of orthopedics there with my good friends, Jim Fickey. Here's my group at Mercy Hospital. Again, my dear friend Ali and his wife joined us, and we had a great time with them here in Baltimore. First, I'll talk about the anatomy. So the syndesmosis is a fibrous articulation between the tibia and fibula. There are 5 key structures: the interosseous membrane, the interosseous ligament, the anterior tibiofibular ligament, the posterior tibiofibular ligament, and the interosseous tibiofibular ligament. Sectioning has been done to see what contributes to syndesmotic instability. Well, the anterior tibiofibular ligament does about 35%. The posterior tibiofibular ligament does about 40%. The interosseous ligament and the interosseous membrane also contribute, but less so. Injury to 2 of the 3 results in syndesmotic instability. The anterior tibiofibular ligament is the most commonly injured, and this anterior inferior articular ligament is seen over here, and it is really intra-articular, and it is a part of Bastias ligament. It's a more proximal part of it. The posterior inferior tibiofibular ligament is the strongest. It's typically the last to rupture. We do see this. This is the posterior aspect of the tibia. Here's the fibula. You can see this pull off a posterior portion of the malleolus. And this avulsion fracture is sometimes ignored, but if it has ripped off with a piece of bone, it may be a way to restore it by putting the piece back to fix the syndesmosis. So look carefully for a posterior malleolus piece. If you could fix it in the face of a syndesmotic injury, you may be able to have a nice outcome without having to rebuild the ligaments themselves. So fixing the bone will help you maintain or reestablish syndesmotic stability. So there have been studies looking at that. And the posterior mal, when it was fixed, restored 70% of the stability. And the syndesmosis was not even as effective as that. So we do recommend strongly looking for that posterior malleolus and fixing it. Now, how do we make the diagnosis of a syndesmotic injury? Plain films can be helpful, but make sure you get full-length films looking for a proximal fibula fracture or a mid-shaft fibula fracture, what we call the Mousavian. Of course, many of you know that we look at the x-rays, we look at the overlap between the tibia and fibula, and on the AP, we look for a decreased tibiofibular overlap, and if it is greater than 6 or 42% of the fibular width, then we consider that that overlap is not good. There should be more overlap, but if it's less overlap, then we know there's syndesmotic instability. Also, we can see on the APM mortis a widened tibiofibular clear space. And if this clear space is over 6, then it is problematic. A normal one is 6, and so over 6 is problematic. So normal films, however, do not preclude an injury. So we are going to be suspicious of these cases when we have tenderness, swelling, and ecchymosis, and usually these will be indicative of a positive syndesmotic injury with a positive stress test. As you see here, this one didn't even need a stress test. You see the widening, the lack of overlap, and you could see that if we had an overlap of 6, that would be normal. If we have a widened clear space of greater than 6, that is abnormal. And of course, we have a clear evidence of a deltoid injury. So if we have a concern for a syndesmotic injury, but we don't see the injury on the x-ray, then we may do an external rotation stress in the clinic or ER. Also, we would do that and look for the syndesmosis as well as the deltoid or the medial clear space widening. So if there is widening, then we would call it a syndesmotic injury. Also, and here's an example of a stress test here without a fibula fracture, and you can see the widening of the syndesmosis, and with stress it gets even wider, and you can see the deltoid also opens up. Now, when you have a fibula fracture that's lower, it used to be thought that you could not have a syndesmotic injury. Well, even the SCR2, the supination external rotation injuries that you see over here, can have syndesmotic instability. So we recommend either stress views by gravity or with external rotation with local or general anesthesia. And you can see here, for example, with stress, this opened up in the syndesmosis here. Even though it was a Weber B type SCR2 fracture, we had syndesmotic injury. Many times it's because there is some comminution of this fibula piece, or sometimes an injury of the Chaput tubercle on the lateral aspect of the tibia. Now, if we're still suspicious, we may use a 3T or a regular 1.5T MRI. We wrote a paper on this with my musculoskeletal radiology colleagues at Hopkins, looking at the utility of a 3T MRI. And certainly we could see very beautifully the fibers of the deltoid. We could also see the elements of the spring ligament as well. And we can see the posterior inferior tibio-fibular ligament, as well as the anterior inferior tibio-fibular ligament, as you see here on this view of the 3T MRI. Now, another way to look for injury is a weight-bearing CAT scan. Now, unlike the MRI, the weight-bearing CAT scan gives us some information as to the functionality of the syndesmosis. So if we have damage to the ligaments on MRI, we don't really know, does that mean that it's intact or not intact from a functional point of view? So the weight-bearing CAT scan will generally show us that it is functionally intact or functionally not intact. So if we have weight-bearing MRI, if we have a weight-bearing CAT scan, we could see the effects of the torn syndesmotic ligaments. And I want to thank my colleagues at Hopkins, Jeff Sweardson and Guarav and John Carino, who we did a series of weight-bearing CAT scan studies. And Ali Mousavian, as you see over here, was very, very instrumental in many of these studies. He particularly was involved in doing syndesmotic measurements, and this is from one of his papers and presentations, looking at the various CAT scan ways to measure the displacement between the fibula and tibia. And I'm not going to go through all this now, but suffices to say there is many different ways to look at this injury with a weight-bearing CAT scan. And you can see here the distance between the fibula and tibia. And you can see that the fibula is not sitting in the incisura. There's a nice angular measurement that I think is very helpful. And you draw it between the anterior part of the fibula and the anterior part of the tibia, and also the posterior part of the fibula and the posterior part of the tibia. And as this angle gets more acute, as it gets closer down more, then we know that there is a diastasis between the fibula and tibia. So this angle here, as you can see in this image, is 65, so it's very large. And this one is more acute, indicative of syndesmotic injury. And this is something that is a whole nother lecture that Ali should give to you on weight-bearing CAT scan and all the wonderful things that he appreciated with his studies. You could look at the lateral clear space and the medial clear space. You could look at talus rotation. You could look at talar tilt. You could look at fibular length. And we found that these measurements were really good in terms of reproducibility and reliability. And even with people of lower level training, we found that people, the values were very good. So, and we looked at the weight-bearing CAT scan versus non-weight-bearing CAT scan, and we saw that there was a significant difference in the cases where there was weight-bearing. We could see the syndesmotic instability very clearly. We did a whole number of studies, and again, I'm just going to say that Ali's an expert in it and really helped change the way I practice medicine. So weight-bearing CAT scan, I find very useful. And as you can see in this case, here's the affected side with weight-bearing. You could see that this fibular fracture is not just a simple fibular fracture. It's associated with the displacement of the syndesmosis, the fibula out of the syndesmosis. And in the non-weight-bearing, you could see some gapping more posteriorly, and this fibula is translated a bit anteriorly, but certainly on the weight-bearing study, we see a lot more dramatic shift. And here's the weight-bearing here versus non-weight-bearing. Again, a more dramatic shift in the fibula moving anteriorly. So what are the indications for fixing it? Well, we know from Bowden's study in '89 that basically with sequential transection, the interosseous membrane got wider and wider. And certainly when the deltoid is deficient, we feel it is more important to address the syndesmosis. But I would say no matter what, we are fixing the syndesmosis. And oftentimes I am also fixing the deltoid. Certainly as from Bowden's study, we found that the syndesmosis is going to be ruptured as you are higher and higher from the ankle joint. So over 3 to 4 millimeters from the ankle joint, you will need to fix the syndesmosis. So Yamaguchi did a study in foot and ankle, 1994, case series of Weber B fractures, and found again what Bowden found, which was that we need to fix the syndesmosis routinely if the fibula is fractured above 4.5 centimeters above the joint. However, the fracture level does not mean that we don't have to fix the syndesmosis if it's lower. So we have this study from Tornetta and company, and basically found that the Weber B fractures, 39% had syndesmotic instability. Now, what do we do if we have a syndesmotic instability? How do we fix it? Well, screws have been conventionally recommended, either 3.5 or 4.5. Usually I use 3.5 or 4.0. Typically I'm doing 4 cortices, and the reason I do it is because it's more stable. And if it does break, I have an easier chance to remove it if it's coming through the medial cortex. Some people like to do 3 cortices because it allows for progressive motion and loosening of the screws. Generally, we do the screws parallel to the plafond, about 1 to 2 centimeters proximal to the plafond, and about 25 to 30 degrees oblique, as you see over here, because you're going midpoint fibula and you're going to end up a bit posterior to the saphenous vein, just on the anterior aspect of the medial side of the tibia. So that, be careful though, the saphenous vein is always there. Now, if we use a suture button configuration, sometimes we do it with through a plate. Sometimes we do it through washers, but if you have a fracture, you do it through the plate typically. And if you have no fracture, we do recommend using a plate to help dissipate the forces. And if you are doing two suture button constructs, we recommend deviating them so that you get more of a mooring-like effect of the fibula to the tibia. And one tether it will be helpful, but two, tether it better, like putting a boat against a dock. You have two tethers that help hold it and with more stability to the dock. So typically we recommend dorsiflexing the ankle, but that has been challenged by Tornetta. I do still like to do it because I will use a clamp, a pelvic reduction clamp, and if I squeeze it and don't have the ankle dorsiflexed, sometimes you will have subluxation of the talus inferiorly. These days, more literature's pushing more for the suture button constructs. Fewer people are doing screw constructs, but for a more proximal fibula fracture, a screw construct may be better because you can maintain positioning of the fibula, especially if it's broken proximally. I'm a big fan of doing fixation of the Maisonneuve fractures unless it's in the proximal third of the fibula, and that helps to get rotation of the fibula in the incisura and get a better reduction of the syndesmosis down below at the ankle. Now, screws are less expensive than suture buttons, but you then have to take the patient back to the OR for removal, and that could add expense to the surgery, obviously. Now, my son, Jason Schon, actually wrote a study just recently in Foot and Ankle International looking at 3D CAT scan analysis of screw and suture button fixation. I had nothing to do with this paper that he wrote, but basically showed that the one suture button repair technique was as good as screw fixation, but that actually two were significantly better at decreasing the volume of the syndesmosis. So shooting those two suture button in a divergent fashion can be more helpful. Now, how do you assess reduction? These days, we're looking at modifications of C-arms. There's ways to do it with a scope. And some people are recommending actually direct repair of the ligament. I certainly like to do a fixation of a fracture fragment. So if we have a Chaput fracture or a Wagstaff fracture that anchors the syndesmosis anteriorly, or a posterior malfracture that anchors the syndesmosis posteriorly, I recommend fixation. I'm going to quickly go through this case. This is a syndesmotic injury. It didn't look so bad. You can see here on the MRI that we did have some edema in the fibula. We had some changes in the ligaments anteriorly and posteriorly. And you can see here that the fibula is not in the incisura. If there's no instability, but the patient has pain, we may do a scope and clean out the space. And then if there's instability, we'll fix it with screws or a suture button construct. So here I am cleaning out my syndesmosis and then fixing it with two screws. If it's unstable and there's no fibular malunion or fibular malposition, then certainly I will do a scope debridement of the syndesmosis and then fix it with either screws or the suture button technique that I had shown earlier. oftentimes I will drill on a delayed case, I will drill the tibia fibula articulation with a K-wire on oscillation mode to activate healing, especially if it's not done acutely. And so that's what that looks like. Now, if we have a deltoid injury, I will not only fix the syndesmosis, but I will fix the deltoid. So here I'm taking the cleaning up the anterior edge of the medial malleolus, taking out a piece of bone, putting in some K-wire tunnels, and then pulling the superficial deltoid into the bone. So I recommend doing it. Now, what about chronic instability? If we have chronic instability, you typically will have a patient who has got a lot of ankle pain and maybe on the way to arthritis. It's a very poor prognosis. And typically, it is correlated with malunion of ankle fracture bony elements. So when we do a revision, we need to debride the syndesmosis. We need to oftentimes restore length to the fibula by cutting the fibula, putting a laminar spreader there. Then we hold the tibia to the fibula with the wire, and then hold it reduced, put on our pelvic reduction clamp, as you see, and then put in a bone graft between the proximal and distal end of the fibula and plate the fibula. Also, in those cases, we will also do a ligamentous reconstruction. There's several ways to do this. This is a paper by Morris, which showed a very simple semitendinosus autograft reconstruction with nice results. We have done studies as well in our labs that showed different ways to fix the syndesmosis. And I'll show you a technique that we use clinically. Here you could see the wide syndesmosis. And in this case, I'm using a semi-T allograft. And you'll see I'm going to squeeze my bones together and then put in a tightrope proximally. Here's my pelvic reduction clamp, and now I'm getting ready to drill my graft across the fibula to the tibia, and then I'm going to drill a tunnel from the medial aspect of the talus to the lateral aspect of the talus, and I'm going to wrap the allograft around the fibula and back towards the medial side, out the tibia, and then into the talus, and then fix it by pulling on it and securing it on both sides with Biotine adhesive screws. Here's the screws going in. And so reduction with two endo button constructs and the allograft as well. And again, if you have a malreduced fibula, I recommend doing a lengthening of the fibula and then doing the allograft wraparound technique, which can give you a nice reconstruction. I do not like tibiofibular arthrodesis. I find my patients are uncomfortable. So in summary, do stress views pre-op if operative indications are unclear. A weight-bearing CAT scan has a role. MRI shows ligaments but doesn't tell us about function. Always do a stress view intraoperatively after fixing the bone. Location of the fibular fracture doesn't necessarily correlate with syndesmotic injury. I strongly recommend fixing the posterior mal and consider fixing the deltoid. Also, those fragments of the chapu and of the wagstaff on the fibula, on the anterior inferior tibiofibular ligaments, those should be fixed. Suture button fixation and screws are good. For syndesmotic fixation, for chronic injuries, assess the fibula position and do ligament reconstruction with allograft. Thank you so much.
Thank you very much. Very great talk and presentation. We enjoyed it. The next speaker is Dr. Schon again about surgical management of failed rostrum operation. In his practice, Dr. Schon usually does rostrum for about more than 90% of cases of lateral instability, but we don't know how he reconstructs the lateral side in failed rostrum procedure. So I don't know that Dr. Schon is with us in person or not now. Let me see.
He is online.
Dr. Schon, do you want to talk in between the talks? Or we can continue the talk, and after that, maybe you can answer the questions. So, are you ready to show the talk, Dr. Khabiri?
I'd now like to discuss the failed rostrum surgery. So the failed rostrum surgery, I think, is a challenging condition, and I think requires some tricks up your sleeve. So here we have an ankle that's unstable. Of course, if you have ankle instability, you may have other things as well, and you may fix the ankle instability and leave, for example, a coalition. So please always think of why this failed, and perhaps there's something else going on. Now, when I do my standard rostrum procedure, I'm augmenting it with a periosteal rotational flap. And so this is how I do that technique. So I'm going to elevate this periosteal flap, and you'll see I'm peeling it off here. And then I have this piece of tissue, and I bring that tissue over my repair. So I'm going to repair the ligament to the bone, and then over sew this periosteum. So this is my standard, and this is how I think I have a very low incidence, maybe less than 5% incidence of coming back in to do a rostrum revision. I put K-wire tunnels in the fibula. I use suture. These days I'm using fiber wire, polyethylene, polyester suture, 3.0 or 2.0. If you have somebody very thin, you should use smaller suture so that you don't have knots. I'm pulling the ligaments into the bone, as you see here. And then I will tie the knots and then sew the periosteum over it. We looked at this and published in the literature with my partners, John Campbell and Greg Guyton. And we basically showed that if you do early weight bearing and avoid plantar flexion, version and 30 degrees of plantar flexion or more is to be avoided. They could do full dorsiflexion and eversion, perineal strengthening, boot braces. They wear a night splint in my practice for 10 weeks, and then they can increase their activities as tolerated based on how they're progressing. Now, what if they have hypermobility? Well, then we may choose to do a non-anatomic reconstruction. And there's the Christmas Snook and there's the Larson. These are two different techniques for weaving the peroneus brevis through the bone. And here you can see I'm pulling it through the fibula. And this is half the peroneus brevis, not the whole. And then I'll pull that down underneath the peroneus braining tendon and the longus and tuck it in a tunnel. You see over here going underneath the tendons into that tunnel. And then I drill a hole from lateral to medial, avoiding the tarsal tunnel on the other side, and suck that through and put a interference screw to help hold that in place. Now, what if we did a reconstruction and it failed? Can we augment it with something other than natural tissue? And the answer is yes, we could use a synthetic tissue. So here I'm doing a synthetic material. So here I'm doing my periosteal flap in a case that had previously had a repair elsewhere. I'm chiseling off the front of the fibula. I'm driving my wires into the fibula. And now I'm going to pass my suture through the ligament and pull that to the bone. And then before I tighten everything up, I'm going to put in my synthetic material. This is the internal brace that I'm putting into the fibula, and another limb is put into the talus, just anterior to the shoulder of the talus, avoiding the penetrating the joint. Either the subtalar or the ankle joint must be avoided. So take x-rays to make sure that you're avoiding it. So here's my suture in the talus. I have my ligament all set to be pulled into the bone. And then I'm going to oversew my periosteum over that. And then I'm going to put the internal brace over that repair. So here I'm pulling in my ligament. And then at the very end, here's my ligament pulled into bone. My periosteum flap now is placed, and then I will pull my internal brace over that as well. Now, we could also do an allograft reconstruction, and here's a semitendinosus allograft. And this patient had 4 prior failures, not by me. And you could see there was anchors there before. I'm drilling a hole in the talus neck. I'm going from lateral to medial in this case. And I'm also going to make a tunnel from the calcaneus laterally to the medial aspect, posterior to the tarsal tunnel. And then I'm going to make another tunnel from front to back in the fibula. And you can see the old anchors. That's not from my repair. That was from somebody else's repair. I'm going to augment this with stem cells from the iliac crest. So here we had so many incisions, I had to be very careful. I pulled my allograft in through the lateral aspect of the talus neck, and from lateral to medial, this medial incision was made. And I pulled the allograft through there. As you can see here, this is medial, this is lateral, and I'm tunneling it under all these previous scars. As you can see, this patient has. I'm reaching with my hemostat. I'm pulling that out the anterior aspect of the fibula. And now I have the drill hole there that was made. I'm pulling that through from front to back. And then I'm going to take this, tunnel it underneath the perineals to the lateral aspect of the calcaneus. And then I'm going to tunnel that. If you remember, we made the drill hole from lateral to medial there and pull it out medially. So we have the tissues here medially on both sides. I can pull it as tight as I want. And I use interference screws to hold that in place. And that worked out very well. Thank you so much. It was an honor to be here. I wish we could all be together and continue to make the world a better place. Thank you so much. Bye-bye.
Thank you very much. Very great presentation. Dr. Schon is with us within his operations. Thank you very much. He finished his presentation about 3 or 4 a.m. and started operation about 6 a.m. And maybe he needs some sleep after operations. Thank you, Dr. Schon, for joining us.
Thank you so much for having me.
Thank you. Are you in Mercy Hospital now?
Yes. Yep.
Oh, good. Is there any question? Is there any question? If there is not, I have a very quick question. in your allograft technique, it seems it's something like Christmas-Snook procedure. That I know that you and Dr. Meyerson like this technique for lateral reconstruction in case of failed Brostrom procedure. My question is that after passing the tendon from the fibula, do you turn it on the peroneal tendon or under it to reach to the calcaneal tuberosity?
Usually we're tunneling it underneath. Rarely we tunnel it over the perineal tendons. We tunnel it over if we have a chronic lateral lateral retinaculum insufficiency. So if the perineal tendons are also dislocating chronically, we can use that in those cases to augment. Otherwise, we go deep. Good question.
Yeah, thank you.
Thank you so much for having me. I know we're running out of time, and I will listen to everybody else speak. And again, I will look forward to seeing you all in person. Take care.
Thank you very much. Hope seeing you again very soon. Thank you.
You're welcome.
Thank you. The next speaker will be my friend and colleague, Dr. Matthias Walcher. Dr. Matthias Walcher is working at OCW Württemberg, Paracelsus Private University at Nuremberg. He is a very nice friend, and I like his personality, his knowledge, and especially his accent. I like it. Thank you, Dr. Walcher, for joining us. Your topic is about peroneal tendon pathologies and treatment algorithm.
Good evening, everybody. It is a great honor for me to be invited and be part of this faculty, and it brings back the great times that we had together in Baltimore. It is a shame it is already 6 years ago. Let us all pray for peace and hope for the best for the world. And my apologies, I pre-recorded my talk because I'm on skiing holidays and the internet is a bit fragile. So please run my talk. I'll be there for questions, of course.
Thank you. Dr. Khabiri, do you have the talk?
Is the talk available?
Yes.
Dear faculty, ladies and gentlemen, first of all, I want to thank you very much for the invitation and for the opportunity to talk in this session and be part of this outstanding faculty. I'm going to talk about peroneal tendon lesions and instability, and I want to present you my treatment algorithm. In my experience, the prevalence of peroneal tendon pathologies is massively underestimated. And if we have a quick look into literature, in up to 4% of all ankle injuries and up to 77% of all cases with chronic lateral instability of the ankle, there are relevant peroneal tendon pathologies. They cause pain, they cause functional impairment, therapy is complex. And it is just essential to have a very thorough diagnostic workup, like a good treatment plan to be able to restore function. First of all, let's have a look into functional anatomy of the peroneal tendons. The peroneus longus and brevis run behind the fibula in a retromalleolar groove proximally, although it needs to be stated that it's only in about 80% of the cases a real concave groove. In about 20% of the cases, the groove is configured flat or even convex, making the tendons prone to instability. Nonetheless, the most important stabilizer of the tendons is the superior peroneal retinaculum. If we follow the course of the tendons more distally, there's the peroneal tubercle that marks the entry into individual tendon sheaths distally, and that peroneal tubercle can be prominent in about 29% of the cases. The peroneus brevis inserts distally at the base of the fifth metatarsal, whereas the peroneus longus is running around the cuboid in an osseous canal and inserts plantarly at the cuneiform 1 and the base of the metatarsal 1. Up to 30% of the cases have an os perineum in the peroneus quintus. The vascularity for the peroneal tendons is differing to what has been reported previously, sufficient to allow for proper healing. The clinical function of the peroneus longus, like the peroneus brevis, is active lateral ankle stability and foot eversion. Peroneal tendon pathologies are most frequent in areas of greatest mechanical stress, and these are the fibula tip, the peroneal tubercle, and the cuboid rim. There are tendinites, there are tendon ruptures, there is instability of the peroneal tendons, and there is the symptomatic os perineum. And the two pathologies that I want to discuss with you today is the peroneal tendon rupture and the instability of the peroneal tendons. The origin of ruptures of the peroneal tendons is usually not an acute incident. The vast majority of these injuries is caused by mechanical overloading. And this mechanical overloading leads to chronic inflammation, tendinosis develops, and we see microscopic and macroscopic changes. There's a mucoid degeneration, there's a loss of collagen fibers, there's an enhanced vascularization, there is cell necrosis, and what we can see macroscopically in theaters is a tendon flattening, a change of the color to a dull gray-brown, irregular thickening, and a synovial proliferation and fibrosis. And these initially leads to degenerative longitudinal splitting, ultimately to rupture, and the peroneus brevis is by far more frequent rupture than the peroneus longus. An excellent treatment algorithm to address peroneal tendon ruptures has been suggested by Mousavian and Redfern already in 2004. They divide three types of peroneal tendon lacerations. Type 1, where both tendons are grossly intact. Type 2, where one tendon is torn, but only one is usable. And type 3, where both tendons are torn and both are unusable. And they distinguish between reconstructible and non-reconstructible if more than 50% of the diameter of the tendon is left after very thorough debridement. In type 1 injuries, they suggest to do a repair of the tendons, excise longitudinal splits, and tubularize the tendons. In type 2 injuries, they did always perform a tenodesis, and in type 3 injuries, they did look more proximally, and if the muscle was not healthy, if there was no excursion of the muscle, they did a one-stage tendon transfer to restore function. If the muscle was healthy, they did, if the tissue bed was non-scarred, a one-stage allograft reconstruction. If the tissue bed was scarred, a two-stage allograft reconstruction. It needs to be stated that the overall evidence for these recommendations is weak, and I have to say that I really got a bit of problems with tenodesis, and I also do not like the two-stage procedure for reconstruction. And the reason for this is that tenodesis of the peroneus longus to brevis always means a loss of a partial peroneus longus function. The peroneus longus is a very important antagonist of the anterior tibialis muscle, and if we are losing that antagonism, there's the risk of an iatrogenic deformity, of a pes cavovarius, as a midfoot-driven hindfoot deformity that might jeopardize our reconstruction. So the graft reconstruction here has got some real biomechanical advantages. Still, it needs to be stated that there is no data comparing allograft to autograft. It is a real challenge to address the non-repairable ruptures. If the muscle is healthy, it is clear that we need to go for graft interposition. And there is no clear superiority of allograft or autograft. So if allograft is not readily available for you, feel free to go for the hamstrings. It is just important to do a thorough pre-stretching of the graft before insertion. If the muscle is not healthy, we need to do a tendon transfer, and both the FHL, like the FDL, can supply good outcomes. They can provide a clinical improvement, but not a complete restitution. And if the FHL is used, there's a risk of tarsal tunnel syndrome. I personally do not feel that there's the need for a two-stage procedure, even if the tissue bed of the tendon is really scarred. The level of evidence is weak, and the intraoperative evaluation of the muscle vitality is difficult. So I got personally a very low threshold to do a tendon transfer, and it is unclear if the FHL or FDL transfer outperforms the interposition grafts. So my personal treatment algorithm is a tiny bit different to what Myers and Redfern suggests. I do not perform tenodesis, but I always do an allograft or autograft reconstruction. I do not do the two-stage procedure. I just do not feel that there's the need for it. And I find that it is really important to address biomechanical cofactors that are the very origin of the ruptures of the peroneal tendons. This is the CT of a case that I just did some weeks ago. You can see the massive swelling of the peroneal tendon sheath. You can see the preparation of the sural nerve, that it is still intact. Then I opened the sheath, and then you can see that there is a massive synovial light of the peroneal tendons, and that there is a longitudinal split of both the peroneus longus, like the peroneus brevis. Here you can see the ruptures in detail. And in this case, both tendons were still reconstructible. So I did excise the longitudinal splits, and I did a tubularization of the tendons and a reconstruction of the tendon sheath. And the stitches that I'm using is non-resorbable stitches. And you know, that is really not a problem for the patients on the long term. I brought you the tendinoscopic pictures of the patients where I did a peroneus brevis reconstruction some years ago, and now did a reconstruction of the peroneus longus. And you can see the peroneus brevis is just healthy. It healed nicely, and you can see the non-resorbed stitches through the tendon surface. But really, the stitches do not even reach the tendon surface, so it's not a mechanical problem whatsoever. It is important to keep in mind that there's biomechanical cofactors that can make your reconstruction prone to failure if you do not address them. And this is a pes cavus or a pes cavavarus that you could address with a dwyer osteotomy, like in this patient. A hypertrophic peroneal tubercle that can cause mechanical issues that you can trim down, like in this patient. Overcrowding of the retromalleolar tunnel if there's a very distal muscle belly of the peroneus brevis that can be resected, or lateral ankle instability that you also need to address. Another very important pathology of peroneal tendons is instability that usually occurs in athletes, as it is part of cutting maneuvers that occur in many, many sports like skiing, soccer, basketball, ice skating, and so on. And in this pathology, one or both peroneal tendons displace anteriorly from the retromalleolar groove, frequently after a rupture or an avulsion of the superior peroneal retinaculum. There are two major provoking mechanisms. The first is a sudden eccentric contraction of the peroneal muscle in a plantar-flexed inverted foot, and the second one is a forced dorsiflexion against eversion. The peroneus longus runs more laterally than the brevis, so it is more frequently displaced. There is a classification system for instability of the peroneal tendons that I personally do not use because there's frankly no influence on my therapy decision. It is only important to have a look on the fibula. Sometimes there's a fracture of the cortical rim that stabilizes the fibula, the peroneal tendons, and if this fracture is there, it is always an advantage to be able to refix it. If an instability of the peroneal tendons is established, it is important to look at the level of activity of the patient. If it is no high-level athlete, it is quite okay to go for a non-operative treatment first, with immobilization in a walker orthosis, 2 weeks of non-weight bearing, then 4 weeks of partial weight procedures or rerouting of the superior peroneal retinaculum. And that is also the treatment plan if the non-operative treatment fails. I personally do not do bone block procedures or rerouting procedures of the superior peroneal retinaculum. But let's look into the data that literature gives us to the treatment of instability of the peroneal tendons. SPR reconstruction and groove deepening have excellent outcomes and excellent patient satisfaction. The big advantage of groove deepening is that it decompresses the retromalleolar tunnel. And like this, I have a very small risk of redislocation and an improved return to sports. Bone block procedures and soft tissue rerouting procedures have very relevant rates of complications, like non-union, like tendon adhesions, tendon irritations. So in my hands, I do not use them routinely. It is just the second line of defense that I hardly use ever. This is one of my patients with peroneal tendon instability. They always do a start with a peroneal tendinoscopy, which helps you establishing the instability very well. You can see popping the peroneus longus tendon over the tip of the distal fibula very well. Then I do a longitudinal incision behind the distal fibula. I identify the sural nerve and make sure that I do no harm to it. Then I open the tendon sheath just posterior to the distal fibula, and it is quite enlarged because of the recurrent luxation of the peroneal tendon. Then I just lift it off the bone to make sure that I can identify the distal fibula properly. I use the oscillating saw then to cut just behind the retromalleolar groove. The next move is with an osteotome to mobilize the groove itself. Then a tiny bit of cancellous bone can be taken out with a curette. Then I use a blunt instrument to knock down the groove itself. And by doing so, I achieve the groove deepening itself, and I can preserve the fiber cartilage that is running on top of the bone of the groove, so that the tendon can run smooth even after the groove deepening process. Now the tendons should be running stably, spontaneously. There must not be any subluxation or instability left. If there is, you need to repeat that stages and create an even deeper groove to make sure that the tendons are stable. Afterwards, I do a transosseous refixation of the tendon sheath, like the peroneal tubercle. And as the tendon sheath is enlarged, you can double the reconstruction and just stitch apart still over your first reconstruction. And like that, both the groove is reconstructed very well and the peroneal retinaculum is reconstructed very well, allowing you for a lot of stability. And that is the final result after the doubling procedure. So in summary, peroneal tendon pathologies are frequent. They cause pain and functional impairment. Early diagnosis and adequate treatment planning is essential. Operative treatment is technically demanding. Good treatment planning results in encouraging results. Long healing time and residual complaints are typical. High-level evidence is rare, and anatomically predisposing factors need to be taken into account in treatment planning. Thank you very much.
Thank you very much, Dr. Matthias. Very great presentation. We learned a lot from your presentation about peroneus longus and brevis, how to manage the pathologies of them. And as you said, most of the time we underestimate the amount of problem and pathology of these tendons. Maybe because most of the time these patients have less problem, or the problem maybe get resolved with physiotherapy or shoe modification or something like that. The most important point that I understood that you are against peroneus longus to brevis transfer, which is acceptable, and most of the pediatric foot and ankle surgeons don't agree with this transfer because we need the peroneus longus very much. Otherwise, we may end up with a delayed dorsal bunion deformity without peroneus longus. And
that is true. That is true. There is some nice studies out that show that a very important part of the function of the peroneus longus is to antagonize the anterior tibial muscle. And if you're losing that antagonism, you're risking that the anterior tibia muscle gains overweight and is pulling the foot into a pes cavus and secondarily in a cavo varus. and by so you can jeopardize your result. I mean, as a second line of defense, it is of course okay, and it is worthwhile doing the tenodesis if necessary. But if ever you can avoid to do that, you've done a favor to the patient, and the patients just do functionally better.
Yeah, thank you very much. Is there any other question? I know there are lots of questions, but we don't have much time. Maybe at the end of session. Thank you, Dr. Matthias, for joining us and accepting our invitation.
Thank you very much for having me. It is a great honor.
Thank you very much. Thank you. Very kind and friendly acceptation. Thank you very much. The next speaker is Dr. Gonzalo Bastias with a very great talk about charcot fracture dislocation. You know, Dr. Gonzalo Bastias is from South America, from Chile. He's my friend since many years ago, and he's doing his job in foot and ankle surgery and limb deformity reconstruction. He has many good techniques for alignment reconstruction with internal and external techniques. Thank you very much, Dr. Bastias, for joining us. We can show your pre-recorded talk. Do you want to talk anything at the beginning?
Well, thanks for the invitation. Ali is a great friend of mine, and I'm really glad that I can be here with you today. And I pre-recorded my presentation just to be sure to get in time, because I tend to overspeak, and I know we are short in time. So thanks very much for the invite.
Thank you. Thank you very much.
Hi, my name is Gonzalo Bastias. I'm from Santiago, Chile. Thanks everyone for inviting me to this important meeting. I'll be talking today about reconstruction of the charcot foot. This is my disclosure. Are we going to improve the quality of life of our patient? These are important questions to ask beforehand we start the management of this. One for inviting me to this important meeting. I'll be talking today about reconstruction of the charcot foot. This is my disclosure. Well, the first question I like to ask when I do this talk is when we have to reconstruct a charcot foot. Is it a viable option for all patients? Is amputation an acceptable alternative? And are we going to improve the quality of life of our patient? These are important questions to ask beforehand we start the management of this type of patient that can be very difficult. Sometimes amputation can be like a taboo topic to discuss with our patient, especially in countries where there's a difficult access to prosthesis. And so it's very important to have this talk with our patients beforehand. So what are the goals of treatment for the charcot neuropathy patient? Well, the classic goals are to present stability, prevent bone infection, to make this feet shoe erasable, and prevent recurrence. And this is why mainly all charcot treatment involves like osteotomies or arthrodesis, because we cannot rely on joint correction. So my additional goals of treatment, I think are more modern, to preserve bone stock, avoid deformities, and prevent ulceration. And by this, we will complete the initial goals of treatment, but we will try to be a little more aggressive in this commitment. So for me, what are the keys of success? I think mainly the multidisciplinary approach to assess the vascular status of our foot and ankle, and we had to have some consults with vascular surgery and interventional radiology in case we have some arterial deficiency that may be putting in risk our reconstruction. And I think also, and most important, we have to see some metabolic improvement in this patient. If our patient is not metabolically compensated, probably our plan will fail. So midfoot charcot is one of the main topics in this talk. We know that the midfoot compromises around 60% of all charcot patients. So it's very important for us to have a really good plan on how to tackle these deformities. So this is our menu. It has been described many techniques for establishing a line of management in these patients. The first important thing is that we can have procedures involving exoccectomy or midfoot osteotomy or arthrodesis. This midfoot osteotomy or arthrodesis can be made by means of internal fixation or external fixation or combined fixation. The indications for exoccectomy are no collapse or mild collapse of the midfoot, focal exostosis and ulceration, like in this patient, whereas there's focal ulceration because of navicular-cuneiform subluxation in this location. So this is the exoccectomy taking place, and voila. Well, the osteotomy on arthrodesis involves an open wedge resection and joint preparation, or it can be done by minimally invasive surgery or percutaneous. When we do an open wedge, we have to have open approaches and big approaches, and so we can have like a complete visualization of the area where we're going to do our wedge resection. Here we see an example of a patient having like this triangle, a plantar-based wedge resection of the midfoot and correction afterwards. The minimal invasive percutaneous alternative involves using a Gigli saw with the 4-point techniques described by Lam in order to make a minimal invasive osteotomy, and having afterwards an external fixation to do a progressive correction of the deformity by means of destruction osteogenesis. So for fixation, the internal alternative, it's preferable when we have a non-ulcered charcot patient with non-osteomyelitis, with adequate bone stock and density. And here is where many authors have described the use of superconstructs that involve going proximal or distal to the joint deformity through normal joints. This is a case where we have like a focal and mild collapse of the midfoot. Sorry for the quality of the x-rays, but here we see like we have a classic cuneo-navicular deformity, and here's the resection of the ulcer. We have a plantar approach. We have a wedge osteotomy for correction of the midfoot charcot, and here we can see fluoroscopic images of how we correct this by means of only osteotomy of the first metatarsal, and we did fixation with internal with a plate and 2 cross screws. For external fixation, we have 3 types of constructs. The static construct, that it's a frame that we're just going to use for fixation, that's not going to have secondary movements or secondary destruction. The dynamic external fixation, that it classically involves the hexapod, and a combined approach using internal and external fixation. The static frame, this is an example, a 68-year-old male, very complicated diabetes, a smoker, with this 10-month observation. We have a moderate to severe collapse. So we did perform a wedge osteotomy of the midfoot and with a biplanar component in order to correct the adductus. Here we see how we calculate our osteotomy using K-wires. And this is the correction after the wedge was resected. We pin everything and we put a static fixator in place in order to compress and fixate our osteotomy. Here are the pictures. And here's the postoperative result. It's very important to correct this ankle frame can allow us to correct the ankle equinus before correcting the midfoot, so we can have a real look of our deformity. In case we don't correct the equinus, probably we will have a recurrence of the deformity afterwards. This patient healed very, very well. He's free of ulcers. This is the last X-ray. He didn't want to have any other surgery, so usually we do beams in this kind of patient, but this patient didn't want any. The dynamic frame, here we have a patient, an obese patient, basketball player. He had a sport injury 3 months before, and he was diagnosed with diabetes like 2 weeks ago. And we saw that he had this midfoot Charcot. We did, as he was young and he had very good healing potential and functional, and he was very functional. We perform a correction using an hexapod, where we do the percutaneous minimally invasive osteotomy of the midfoot, and we corrected. Here's the postoperative immediate X-ray, where we start correcting progressively the deformity, and you can see like new bone formation from the distraction osteogenesis and the completely correction of the deformity. Here's at 2 months after he finished his program, and after we removed the frame, we put these beams in the first, second, and fourth metatarsal. This is all a minimal invasive procedure. You can see that he doesn't have any open approaches. Probably what I would do now differently is that the subtalar joint probably shouldn't have to go in order to give a stable construct. That is the patient with a plantigrade foot without ulceration and playing basketball again. So what about ankle reconstruction? Ankle reconstruction involves a tibio-tail calcaneal arthrodesis or a tibio-calcaneal arthrodesis, depending on the state of the talus. I think the main issue on the reconstruction of the ankle Charcot is the status of the talus. In these cases, for example, when we have like a varus deformity, it's usually a good plan to go through lateral, and by means of using internal fixation, we can do a nailing of the tibio-calcaneal arthrodesis with a very good correction, and this probably goes very well in cases where we don't have a very good metabolic control. Unfortunately, we have to do open approaches in these patients, but usually it's better than using an ankle frame. The external fixation, in cases we have very severe deformity with very bad soft tissue, we can do a gradual deformity correction using hexapods, and afterwards we can do an open approach, a minimal invasive open approach, and we can either go into internal fixation or we can persist with the external fixator and compress with using a program or compressing acutely. Here we have a patient where we have like typically varus. This is a non-ulcer patient in aching holes stage 2 deformity, and here we can see that he has very little talus remaining. And what we did was planning a tibial calcaneal arthrodesis, but we were very careful because we didn't have any clearance about if the remaining calcaneus will be enough to fixate that screw for the nail. So we did 3D printing. I recommend, if you have the opportunity of doing it, to have 3D prints of your deformity, especially in the ankle, so you can measure and be safe about your implants. And I think in this case, it was very good for us. We could perform a very good arthrodesis. We have additional screws holding this together, and this go really good, and we could correct the deformity without any issues. This is a very interesting case in a patient who had 2 months of deformity and edema secondary to a mild trauma. He was not ulcerated. This was an acute Charcot. It was like H. Holt's stage 1. And this may be controversial, but nowadays we are doing more surgery on this patient than we did before. And I'm saying that it's controversial because classically we were taught that you cannot touch this. So in this patient that this has a very complicated diabetes, we thought that if we didn't do anything, this probably would ulcerate and infect. So probably we discussed in our team, and we decided to. This is the X-ray. We decided to take the patient to the OR. Here you see that complete destruction of the talus, and this distal fibula was probably going to make an ulcer on the lateral side of the ankle. So in these cases, I do not recommend doing a conservative measure like total contact casts, because probably it will ulcer, and we have to try to take these patients before they ulcer. So what we did was we put an hexapod frame with wires and with just one half pin in order to keep it the most minimally invasive possible. And we did a correction while the patient transitioned into phase 2 in order to align the ankle and start compressing. As you can see, the patient progressed from this acute Charcot to non-inflammatory status without ulcer, aligned. And probably in this context, it was very, very easy to do the second stage procedure at 5 months. During these 5 months, the patient took care of his diabetes and started treatment, and he was doing very well. And afterwards, we went into internal fixation using the beams and doing a tibial-calcaneal arthrodesis. So this patient went very, very well. So take-home message: reconstruction is not for everyone. Remember the multidisciplinary approach. Get your vascular surgeons on it and make very good friends with your metabolic or diabetes specialist. I think it's very important to embrace the new goals. Try to break the acute Charcot management frontiers like we saw in the last case. And this involves bone stock preservation, avoid deformities, and prevent ulceration. Let's not wait until these patients are ulcerated and infected. And probably with very severe deformities, the bone stock is very low. So probably your reconstruction will be harder if you don't take action beforehand. So the main important thing about this is early reconstruction. Thanks very much.
Thank you very much, Dr. Gonzalo from Chile, for accepting our invitation and your great talk and sharing your knowledge and your great expertise, especially in hexapod and frame reconstruction. You are amazing at that, and I hope one day I can see your technique in person. Is there any question from Dr. Bastias? So, thank you, Dr. Bastias. We don't have your voice, Dr. Bastias.
Thanks again for the invitation. Glad to be here and take care this time.
Thank you. Thank you very much. Hope see you soon. Thank you. The next speaker is my friend, Dr. Naderi, orthopedic surgeon in Trito and Mehrad Hospital with very good reputation in foot and ankle surgery in Iran. Dr. Naderi, thank you for accepting our invitation. We are waiting for your great talk.
Hello, it's an honor to be here and to have my presentation in POTA Biennial in Tehran. And I say hi to all my colleagues and my seniors and juniors around my country and well-known professors from around the world. Okay. Sure. Okay. The topic I'm going to deal with is in brief is stress fractures in athlete's foot. As we know, the basic science is that repetitive submaximal mechanical loading that exceeds the reparative ability of bone causes imbalance between bone resorption and bone formation, and it leads to microscopic bone injury, and it will cause a cascade of stress reaction, incomplete fracture, and complete fracture that might be either displaced or non-displaced. About 10% of injuries seen in recreational and competitive athletes are stress fractures of the foot and ankle. And about 80% of these injuries involve tibia, fibula, metatarsals, and calcaneus. The major percent of these fractures occur in cancellous bone versus 23% in cortical bone. These stress fractures are more common in female athletes because they have genovalgum, they have higher Q angles, pronated feet, less muscle mass, and they have also female athlete triad, that is eating disorder, amenorrhea, and osteoporosis. There are risk factors for stress fractures in the foot area, divided into two major categories: intrinsic factors that are cavus feet, leg length discrepancies, excessive forefoot barriers, tarsal coalitions, prominent posterior calcaneal process, tight heel cords, osteopenia or osteoporosis, poor vascular supply, and abnormal hormonal levels. Extrinsic factors that predispose the patient to stress fractures are type of the activity, excessive knee training regimen, poor equipment, footwear, improper technique, type of training surface, and sleep deprivation. The clinical presentation is not quite significant in most cases. The onset of pain is insidious over a period of days to weeks, and there is a history of sudden change in activity or training level, or even the type of the shoes the athlete is wearing. Increased symptoms with activity is the other main clinical picture. In physical examination, the findings are not quite significant. Swelling may not be present in the stress fractures, and there is necessary to assess the alignment and range of motion and gait pattern of the patient. There's usually a tenderness over the involved site that is perceived by bone percussion. To diagnose stress fractures, imaging starts with X-rays that are done in weight-bearing or standing of the position of the affected area. As we know, up to 80% of the X-ray results are negative at the onset of symptoms. So if we repeat the X-rays a few weeks later, we might find preosteal new bone formation as it is depicted here in a metatarsal shaft fracture. CT scan is used to define the fracture line that is already suspected on bone scan or MRI. And it is also used to plan for the treatments, because we can see either the fracture is complete or incomplete, and also the trajectory of the fracture. Bone scan was once regarded as the standard diagnostic test for stress fractures, but although it has 100% sensitivity, it is not specific at all, especially within the first 48 to 72 hours of the onset of symptoms. So it has been replaced by MRI nowadays. MRI is highly sensitive and specific in diagnosing stress fractures. It can show concomitant soft tissue injuries and can be done as the initial imaging modality when high index of suspicion for a stress fracture is present. It is important to note that correlation of MRI findings with clinical signs is quite important, because 43% of the stress reactions, that is bone marrow edema, do not progress to stress fractures at all. Stress fractures are divided into two subgroups. High-risk stress fractures have lower propensity to heal. There is need for more proactive management in terms of restricted weight bearing, casting or immobilization, early operative intervention. They occur more commonly in areas of tensile stress and vascular watershed. That is, they have more propensity for non-union if left untreated. Common locations for high-risk stress fractures in foot area are talus, navicular, second, third, and fourth metatarsal bases, in contrast to metatarsal shaft and head fractures and neck fractures that are low-risk stress fractures, proximal fifth metatarsal metadiaphysis area, and hallux sesamoids. Low-risk stress fractures have high propensity to heal regardless of treatment strategy. Management usually includes a short period of activity modification with full weight bearing, and there is no weight bearing restriction needed. If there is low bone density, prior stress fractures, or female athlete triad, more protective management in terms of casting or cast foot immobilization is recommended. The typical examples of calcaneus, cuneiforms, cuboid, metatarsal neck, or shaft fractures. Here I prefer to deal with two more important high-risk stress fractures in foot area, that is navicular stress fracture and fifth metatarsal stress fracture. Navicular stress fractures occur more frequently in track and field participants. The fracture line is in sagittal plane, that is from dorsal proximal to plantar distal. It involves the central third, that is the watershed area between posterior tibial artery and dorsal pedis artery branches. Regarding symptomatology, vague ankle pain is present. There is dorsal discomfort of the ankle and tenderness along the proximal pole of navicular, where we call it N spot. X-ray is negative in 66% of incomplete fractures and 25% of complete fractures. MRI is the diagnostic tool of choice, where it shows the presence of fracture, and CT will show the fracture trajectory. The classification of navicular stress fracture has been devised by Saxena. It falls into three subgroups. In type 1 and 2, the fracture is incomplete. The dorsal cortical break is type 1. Type 2 is a fracture propagation in the navicular body. And type 3 is a complete fracture with potential vascular, cystic, and sclerotic changes. Non-op treatment is for acute non-displaced partial or complete fractures with a non-weight bearing for 6 to 8 weeks, although operative treatment has been proposed for those complete fractures that are diagnosed acutely in order to return the patient to normal activity as soon as possible, especially in athletes. There is an article from Australia where they have fixed these fractures with percutaneous screws. Operative treatment classically is for displaced fracture and complete fracture with sclerotic changes or in delayed unions. Bone graft is almost always needed to deal with these fractures, and two cannulated screws are used for fixation. There's a technique of fixation because the fracture is usually located in central third. We use a dorsal incision between extensor hallucis longus and extensor hallucis brevis. The two parts of the fracture are separated using a Hintermann distractor to remove sclerotic tissue and to do the reduction more easily. Bone graft is usually used to promote healing and fixation using two cannulated screws. The other high-risk stress fracture is proximal fifth metatarsal fracture. The risk factors for these fractures are cavus foot, metatarsus adductus, and sports that are involving cutting motions. The fracture occurs in watershed area between proneus brevis insertion, as it is evident here, and diaphyseal blood supply. Classification proposed by Torque includes type 1 or acute fractures, type 2 in which delayed union with preosteal and intramedullary bone formation is present, and type 3 that are non-union. In any Torque type, we have to pay attention to plantar gap of more than 1 millimeter that it might affect the prognosis of the fracture union. Treatment for type 1 non-displaced fractures, that is the acute fracture, is 4 weeks of non-weight-bearing cast plus 4 weeks of weight-bearing cast. In type 1 fractures with cavus or adductus, or in elite athletes, in type 2 and 3 fractures, operative treatment is preferred. The typical and classical technique of fixation is percutaneous or limited open screw fixation. The screws that are used are usually the largest diameter possible solid lag screw, but there is some question about the need for solid lag screws because there are studies that recommend cannulated screws, and it has been shown that they work as well. Open repair with bone graft is when significant intramedullary sclerosis or resorption with large diastasis is present, or in fracture cases or non-union after previous screw fixation or broken hardware. There is this nice article about evaluation of two types of intramedullary fracture fixation, a cyclic and ultimate load model. It's an in vitro study. In this study, it has been proven that cannulated screws are as solid lag screws for the fixation of these fractures. There is another technique for this fracture, that is the Ferry technique or two-portal technique that was proposed by Peter Duke and Silvio Cravelli from Institute Rizzoli. In this technique, we have these two minimally invasive incisions. The fracture site is opened minimally, and this technique is like a tension band wiring technique, and they use number 2 fiber wire tape to complete the deconstruct. Thank you for your attention.
Thank you, Dr. Naderi, for your great talk. We have lots of professional athletes with prolonged symptoms of stress fracture or stress reaction, and you mentioned how to manage them. The next speaker, we have 3 other speakers. Thank you, everybody, for staying with us. We had great discussion by now, and now we have Dr. Bahaeddini from Iran University of Medical Sciences with midfoot fractures. Dr. Bahaeddini, can you start?
In the name of God, the compassionate and the merciful, I'm Dr. Bahaeddini. I'm the Associated Professor of the Orthopedic Department of Iran University of Medical Science. In the following 10 minutes, I'm going to talk about midfoot fractures. Let's start with anatomy. Functional anatomy of foot is really important in decision-making of how midfoot fractures should be treated. As we know, functionally, we can divide midfoot and forefoot area into 3 columns: medial, intermediate, and lateral column, which they are outlined with different colors in this picture. The medial column consists of first TMT and navicular-cuneiform joints. In this column, limited motion is available at the first TMT joint, and the mobile segment of this column is the talar-navicular joint. The intermediate column, which is colored in red, consists of second and third TMT joints and navicular-cuneiform joint. This column is rigid and almost no motion is available. The lateral column also consists of fourth and fifth TMT joints, and in contrast to the other columns, the lateral column is mobile and its function is essential in shock absorption during normal gait. As a whole, the foot also can be divided into 2 columns, medial column and lateral column. The medial column, which is in red in this picture, is relatively rigid, and its stability is really important. It serves to make a lever for propulsion during normal gait. In contrast, the lateral column is mobile and serves as a shock absorber and accommodate foot to an uneven surfaces. Beside bony anatomy, ligaments are crucial in maintaining midfoot stability. Ligaments can be grouped into dorsal plantar transverse interosseous ligaments. The transverse interosseous ligaments are the strongest one. As a rule, plantar ligaments are stronger than dorsal ligaments, so under tensile load, dorsal ligaments are first to fail, and dorsal subluxation of metatarsal base is more common. As we know, the midfoot circulation is supplied by the branches of tibialis posterior and tibialis anterior artery. Local blood supply should always be considered in surgical planning. The dorsalis pedis artery crosses these trine joints and courses between first and second metatarsal base to form the plantar arch. In midfoot injuries, this artery may be thrombosed or damaged and can result in hematoma or compartment syndrome. In the initial evaluation of patients with midfoot injuries, we should always take care about soft tissue and any sign of skin tenting. Neurovascular evaluation is also so critical. Plantar ecchymosis is a sign that guides us to look for midfoot ligament injury. Provocative maneuvers such as pronation abduction stress or dorsal plantar translation or midfoot squeezing can cause pain in the area of ligament injury. Imaging studies always should be performed in evaluating midfoot injury. Imaging studies should be started with X-ray radiography. AP lateral oblique view of the foot should be performed initially. If the patient can tolerate it, the standing X-ray is preferred to see the foot alignment dynamically. Due to the complexity of bony anatomy, CT scan is useful complementary imaging study to evaluate bony architecture and intra-articular extension of the fractures. MRI is rarely used, but can be used in evaluating ligamentous structures. We should never overlook the instability that can be associated with midfoot fractures. Whenever instability is suspected but imaging studies are normal, we can use stress imaging under anesthesia to detect stable, subtle instabilities. As we can see in this image, the first and second TMT instability is detected by abducting stress view. Now, briefly, we want to talk about some specific midfoot fractures. One of the important midfoot fractures is the navicular fracture. Isolated navicular fracture is rare, and most commonly it occurs with other midfoot injuries. It can be classified as a stress fracture, which is mostly occurring in athletes, and acute fractures. Acute fractures are subclassified into avulsion fracture, tuberosity fracture, and body fracture. The navicular body fracture is also subdivided into 3 categories. In type A fracture, the fracture line divided navicular body into dorsal and plantar segment. In type B, the fracture line divided the navicular body into medial and lateral segment. And in type C fracture, there is comminuted fracture in navicular body. In the case of a stress fracture, the rate of non-union is high in displaced fracture, so ORIF is recommended. But in non-displaced fracture, non-weight-bearing cast for 6 to 8 weeks is the preferred method of treatment. In case of avulsion fracture, which is most common type of navicular fracture, any sign of instability guide us for surgical management. But if there is not any sign of instability, in spite of fracture displacement, non-operative treatment with Walcher boots for 2 to 6 weeks is recommended. In tuberosity fracture, non-operative treatment with walking boots for 4 to 6 weeks is the most common treatment modality. But in cases of tuberosity fracture with significant retraction, that union is not suspected, and in cases of symptomatic non-union or painful medial eminence, operative treatment with leg screw fixation or surgical excision of fragments and kidney procedure is recommended.
Dr. Bahaeddini.
Dr. Mousavian, do you have my voice? Medically unfit for surgery, non-operative treatment with non-weight bearing cast for 8 to 10 weeks is recommended. Another important midfoot fracture is cuboid fracture. Isolated cuboid fracture is also rare, and it occurs most commonly with other midfoot injuries. The 2 predominant types of cuboid fracture is compression fracture and avulsion fractures. The cuboid avulsion fracture is associated with calcaneocuboid ligaments. It is the most common cuboid fracture and often misdiagnosed as a simple ankle sprain, but careful physical examination revealed that the maximum point of tenderness is at the calcaneocuboid joint. Compression fracture of cuboid, in contrast to avulsion fracture of cuboid, required a significant amount of energy. One of the compression fracture of cuboid is called nutcracker fracture, which the cuboid compressed between calcaneus and the abducting forefoot metatarsals, like a nut in a cracker. The importance of these fractures are their association with Chopard and Lisfranc joint injuries. In the management of cuboid fracture, lateral column length and preserving lateral column mobility is important. Any displacement of the fracture can cause degenerative arthritis of the calcaneocuboid or 4th and 5th TMT joint, which is poorly tolerated. Any displaced fracture or shortening of the lateral column is indicated for operative treatment. Isolated cuboid fracture without displacement and maintaining the lateral column length can be treated non-operatively with short leg walking cast for 3 to 4 weeks. Isolated cuneiform fractures are also rare. They are mostly occur in conjunction with TMT joint instability and injuries. In case of cuneiform fractures, we should always look for subtle TMT instability. Stress views may be needed, and because of the complexity of the anatomy, CT scan is mandatory for better evaluation of these fractures. For the management of cuneiform fractures, medial column length and midfoot instability are the criteria that we should consider. Displaced fracture with shortening of the medial column and associated with midfoot instability are indications for operative treatment. Isolated non-displaced fracture with normal medial column length can be managed non-operatively with short walking cast for 4 to 6 weeks. And finally, take-home message. Mid-foot injuries are rare in isolation. They are often associated with concomitant foot injuries. We should always assess for other injuries. Advanced images such as CT scan or a stress view may be needed. Functional anatomy and foot biomechanics should be considered in treatment of these injuries. Thank you very much.
Thank you very much, Dr. Bahaeddini. Great talk about mid-foot fractures. We don't have any time, but there are 2 other great talks that they are already, we have them and we can show you these presentations. The first one is from Dr. Ettehadi, and it was great talk about Jones fracture. I recommend you to stay with us with this presentation. Dr. Ettehadi, please.
Hello, everybody. My name is Dr. Hossein. I'm from Iran. Thank you for having me in this great session. Today, I want to talk about the Jones fracture. As you know, the metatarsal fracture is very common among athletes, and the fifth metatarsal fracture has the highest incidence in trauma patients and athletes. So roughly most acute fractures can be treated non-operatively, but chronic or acute non-chronic fracture are usually needs operative management. So regarding the anatomy, the fifth metatarsal bone articulates with the cuboid bone proximally and the fourth metatarsal bone medially. The sagittal motion of the fifth metatarsal bone is very important for walking, especially on uneven surfaces. And the fifth metatarsal bone has 2 growth plates and also has an apophysis, so lateral growth at the base. And also it has 2 curves in sagittal and axial plane. That knowing these curves is very important for decision making regarding the starting point and the prevention of medial screw penetration. In this picture, you can see the attachment of the peroneus brevis and the plantar fascia, that the attachment of the peroneus brevis is more distal and dorsal compared to the plantar fascia, and attachment of the peroneus tertius, which is at the proximal, at the more distal, at metaphyseal diaphyseal junction. So the metatarsal growth plate initially closure between 11 to 14, and complete fusion usually occurs at 17 to 18 years old. Regarding the motion, because the distal part of the fifth metatarsal bone is much more mobile compared to the base, so the area between these 2 areas is under much more pressure, so it's very susceptible for Jones stress fracture. Also proximal or distal to this to the Jones fracture, we have the proximal avulsion fracture and the distal oblique metaphyseal fractures, that both these fractures can be treated non-operatively. And regarding the vascularization and the circulation, at the top and at the base, we have metaphyseal arteries, and we have the nutrient artery, which enters from the medial side. And between the metaphyseal arteries at the base and the vessels of the nutrient artery, we have a watershed area. That fracture in this area is very susceptible to leads to the non-union. So we have some predisposing factors: hindfoot varus, midfoot cavus, and tarsus adductus, that all of them resulted in overload on the plantar and lateral part of the foot. So in this picture, you can see the milestone of the Jones fracture. In 1902, Sir Robert Jones first described this type of the fracture. In 1960, we have the Swart classification. 1978, Roger Mann described the intramedullary screw fixation. 1984, we have Torr classification. And 1993, we have Lawrence classification. On the left picture, you can see the Swart classification. It classified into 2 types, tuberosity type and the joints types. And on the right side, you can see the Lawrence classification. That's very common nowadays. So Zone 1, Zone 2, Zone 3. In Zone 1, the fracture line enters to the 50 empty joint. In Zone 2, the fracture line enters to the articular surface between the base of the fourth and the fifth metatarsal bones, and the zone 3, that's 1.5 centimeters distal to the zone 2 fracture. And we have torque classification that all of the fractures which is classified in this category is assumed to be a stress fracture. Type 1 is acute fracture. We have lateral sclerosis without any medial sclerosis. Type 2 is a medullary sclerosis that the patient and also the patient has prodromal symptoms, is a stress fracture. And type 3 is non-union and the gap with medullary canal blocked. And the signs and symptoms, it's very clear that in acute fractures, patients had pain at the base of the fifth metatarsal. The amount of the swelling is related to the degree of the chronicity. We have to check the first metatarsal plantar flexion and the hind foot alignment. In subtle or moderate hind foot varus in primary injury, it's not necessary to correct it, but in the chronic cases, maybe you have to correct the hind foot alignment. For starting, we usually order to review a standard X-ray. If on physical examination, the clinical findings are suggestive of the fracture, but you can't see any fractures in a standard X-ray, please order AP ankle view to rule out any avulsion fracture. We use oblique view for classification. In the chronic cases or occult fractures, maybe you need further imaging, check vitamin D level in elite athletes, and usually you don't need to check the bone.
In our practice, we usually have T1 and T fat set sequences, but it is very important this classification to have T1 fat set GAD enhanced sequence, because this sequence can differentiate different classes of vascularity. We have 3 classes of vascularity according to this classification. Class A is when we have just ischemia, and so we have hypersignal in T1 and hypersignal in T1 fats enhanced because we have bone edema. In class B, we have both ischemia, which is colored in red, and also partial necrosis in the proximal part of the bone, just adjacent to each other. So we get, again, hypersignal in T1, but in enhanced sequence, we have the ischemic part is sclerotic, but is enhanced, but the necrotic tissue is not. So we get mixed hypo and hypersignal in T1 enhanced. And in class C, with total necrosis, we have hyposignal in both sequences. So let's get back to the previous question. What is the salvageable lunate according to this classification? Class A and B are considered salvageable, and Class C is unsalvageable. You see that this classification is very useful when you're dealing with a patient with Kenbach disease, and especially if you are going to use vascular bone graft as a part of your treatment strategy. I highly recommend you to read the original article by Schmidt. This is the article I'm talking about. Another important classification to answer the former question is Bain classification, which is based on arthroscopic appearance of the cartilage. If the cartilage is lost, or if it has fibrillation or fissuring, it is considered non-functional cartilage. And the number of non-functional cartilages determine the stage of disease from 0 to 4. If we have 2 or more non-functional cartilages, the lunate is considered unsalvageable. It means stage 2A or more. Finally, this article written by Lichtman and Bain, they tried to pull all of these 3 classifications together and provide us with a new algorithm for 21st century. And even though this article is super informative, the algorithm they eventually came up with, this algorithm or this protocol is a little bit complex, at least for me. And I think that's why at the end of the article, the authors stated that it is not an algorithm for all surgeons and all patients, and the final decision comes down to 2 important factors. What can the surgeon offer according to his abilities, training, and experience, and what does the patient want based on his desires and lifestyle? For example, in Iran, we know that many patients are not happy with arthrodesis of any kind, no matter it's total or partial orthodesis. And that's why we still do radial shortening in some advanced cases, of course, in selected cases who don't want to lose any motion. And we published our work in this journal. We showed that we have 42% of good and 54% of fair result, even though we had no excellent result. But we showed that radial shortening still works relatively well in some selected patients who don't want to lose any motion. And this is another new algorithm published in the last edition of Green Textbook a few months ago. It is more or less the same as the previous algorithm, but it is also, again, a little bit complex. But all of these new algorithms has one thing in common, and that is the status of lunate. They are, in all of them, the most important factor is the status of the lunate itself, using the Lichtman, Schmidt, and Bain classification. So to simplify those algorithms, I just mentioned that we have 3 states of lunate: intact lunate when the lunate is only sclerotic. So the treatment is unloading procedures. And we have a couple of unloading procedures, but the most commonly used are radial shortening for ulna minus and capitate shortening for ulna plus and ulna 0 variants. The second stage is when the lunate is compromised, but it is still salvageable. Like here, you see we have a sclerosis, but we have also partial collapse in the proximal part of the bone. So in addition to unloading procedure, we need to reconstruct this partial collapse with a kind of bone graft. So the treatment is vascular bone graft plus unloading. And among the different vascular bone graft procedures, I personally prefer 4 and 5 extra-compartmental orthopedic graft. It's one of our cases with salvageable lunate partial collapse. We do the same vascular bone grafts, and just to unload it, we simply put a K-wire from scaphoid to capitate temporarily for 3 months. And the final stage is when the lunate is unsalvageable. So we have to go with wrist, with motion preserving procedures or wrist orthodesis. And the choice between these two depends on the extent of degeneration. About the extent of degeneration, we already mentioned that the degeneration starts in central column and then goes to radial column. So if this joint space is involved, or even this one is added, or even the scaphoid is rotated, but the radioscaphoid joint is intact, it means that we still can preserve a part of wrist motion, and we can go with motion preserving procedures such as STT, scaphocapitate fusion, or proximal root carpectomy. Which one is better? It depends on the state of capitate head. If the capitate head and lunate fossa are not degenerated, proximal root carpectomy. And if they are degenerated, some authors prefer proximal root carpectomy with capsular interposition, and some other authors prefer limited orthodesis. I personally prefer the second one. And when it comes to limited orthodesis, the choice between STT and scaphocapitate fusion, I always prefer scaphocapitate fusion because it is technically much easier. This is one unsalvageable lunate, so we excise the lunate and fix we did the scaphocapitate fusion, just single screw in single joint space, very simple technique, and you see that almost always you get sound and solid fusion.
Dear comrades, time is over.
Okay, thank you very much. Just had one slide about the capitate shortening. Just this slide, I finish it. If the radioscaphoid joint is involved, we go with total wrist orthodesis. It was a technical point. I don't talk about it. Thank you very much, and I'm ready to take any question in discussion session. Thank you.
Yeah. Thank you very much, Dr. Mousavian. It was very interesting things that you have mentioned in your lecture. And now the last speak would be the peroneal fracture dislocation by Dr. Fattahi, that is going to tell us some pairs of the treatment of the peroneal dislocation. Would you mind, Dr. Fattahi?
In the name of God, with the permission of my esteemed professors, I will begin my lecture about peroneal fracture dislocation. Peroneal fracture dislocation is a complex injury of the wrist. The mechanism of injury is forceful wrist extension and ulnar deviation. It is a high-energy trauma, and injury progresses through several stages. Usually it begins from radial side of the wrist and progresses to the ulnar side of wrist. In physical examination, dorsal displacement of the corpus may be seen. Patient may have significant swelling, and evaluation for compartment syndrome is mandatory. If lunate is displaced into the carpal tunnel, median nerve symptoms may be present. A radiographic evaluation includes at least PA lateral and oblique views. Fluoroscopy is important in operating room for evaluating of success of close reduction and fractures. CT scan can done several days later. MRI has no role in emergency situation. In PA X-ray, we should consider the gilula line, and in lateral view, the scaphoid lunate and luno-capitate angle should be measured. In peroneal fracture dislocation, X-ray usually obvious. As you can see in this X-ray, the corpus displaced dorsally, and collinearity between the distal of the radius and lunate and carpal bones is lost. In the AP X-ray, you can see disruption of the gilula lines. But sometimes X-ray is subtle, and it is the cause of missing of this injury in initial evaluation in about 16 to 55% of the patient. In PA view, we have P sub pi sign. SPLT cup sign in lateral view that indicates subluxation of the lunate. For better treating of this patient, surgeon should be know normal anatomy of the wrist. You can see the palmar extrinsic ligament in this slide and dorsal extrinsic. Zone of vulnerability to injury divided in two types, lesser and greater. Lesser arc injury is a pure ligamentous injury, and according to the Mayfield classification, have 4 stages. In greater arc, the osseous structure also failed, and according to the site of the osseous injury, the fracture dislocation named, such as transscaphoid prelunate fracture dislocation. Before treating patient with this complex injury, the surgeon should be answered best time of patient, what is the optimal surgical approach, which most given the definitive treatment after complete diagnosis and preparing of the equipment. What is the best time of operation? This slide is an example for transscaphoid fracture dislocation, and in the below of this slide you can see the results after reduction of this complex fracture dislocation. Thus, initial treatment include close reduction with adequate sedation or under general anesthesia in the operating room. Early surgical reconstruction can be done if swelling allows. Immediate surgery needed if there are signs of the median nerve compromise, and we can postpone definitive surgery if early intervention is not necessary. Technique of close reduction is Tavernier method. What is the optimal surgical approach? The dorsal approach is a routine approach for peroneal fracture dislocation, but in presence of volar dislocation of the lunate and compression of median nerve, combined volar approach and dorsal approach are necessary. After reduction of the lunate into the lunate fossa, we can repair the midcarpal ligaments. Which bones should be immobilized? After reduction of the lunate in the lunate fossa, it is temporarily fixed by a pin, and after repairing of the damaged ligament, this repair reinforced by supplementary pins, and the proximal and distal row connected with other pins to normalize the deforming forces. What is the best method of the fixation? In our example case, the styloid fracture is fixed by a pin, the scaphoid fracture fixed by a Herbert screw, and the distal row connected to the proximal row by a pin. In this patient, due to fracture at the base of the second metacarpal, the second metacarpal fixed to the third metacarpal via transmetacarpal pins. Thus, in peroneal fracture dislocation, the scaphoid should be fixed rigidly by a screw. The ligaments should be repaired and supplemented by a pin. Although the concomitant fracture of the scaphoid and scapholunate ligament injury is rare, when it present, it should be repaired by anchor suture. Thus, transscaphoid peroneal injuries require reduction and the fixation of the fractured scaphoid by a screw. Most of these injuries best treated by open reduction, internal fixation via volar and dorsal approaches. All ligamentous injuries should be repaired, and open repair supplemented by pin and screw fixation. What's about the prognosis? As I mentioned previously, the peroneal fracture dislocation is a high energy trauma, thus cartilaginous injury is common, and as you can see in this slide, the cartilage of the capitate is lost, thus subsequent DGD is inevitable. According to a study by Herzberg and colleagues, 14 cases followed for mean of 8 years, all treated operatively, 11 dorsal approach and 3 via combined dorsal and volar approaches. Mayo risk score were excellent in 5, good in 3, fair in 5, and 1 patient had poor results. All cases had radiographic arthrosis that did not correlate with Mayo scores. Thank you for
Thank you very much, Dr. Fattahi. If there is any question about these subjects that has been discussed, before that, I would ask 4 questions from each speaker related to their lecture. For example, Dr. Dianat, have you ever confronted with a case that you do the proximal row carpectomy in acute phase? Is there any experience with that you had to proximal carpectomy in the acute phase of the fracture of the scaphoid?
I don't. I don't think so, because the first fracture, an acute fracture, don't needed any proximal carpal row carpectomy, because fracture, it depends the fracture line, and if isolated fracture of the scaphoid, I think there is no any way for proximal row carpectomy.
Thank you. Any other? Thank you very much, Dr. Dianat. Any other objection to this question? That do you do the proximal carpectomy in acute phase? Although it's in the literature, especially when it is combined with the peroneal fracture dislocation, that you have to do it, especially if the radius is also, the siloid of the radius is also broken. Dr. Ahangar, would you mind to tell us what is your time limit for non-union? For example, Slutsky has said after 5 years of non-union of the scaphoid, what I have got is not very successful experience with the treatment of the non-union of the scaphoid. What is your time limit for doing the non-union of scaphoid treatment?
Hi, Dr. Lahiji. Good night. In my opinion, the time is important, but not a strict indication for selecting the type of operation. If we have no degenerative arthritis around the scaphoid, and the age of the patients is low, in my opinion, lower than 40-45 years, I do bone grafting like young patients. If the age of the patients after that, I suggest the patient the other options to operate the non-union, like for corner fusion, proximal row carpectomy, and even in older patients, I suggested the wrist denervation. Wrist denervation is the good option for the lessen the pain of the patients and reserve the motion.
Thank you very much. I mostly agree with you that in very old, we should consider the other options. And one question from the peroneal dislocation, Dr. Fatai. Have you ever done, there is a article, I think in 2012, in Journal of Hand Surgery of the India, that has said in very old, after 3 months, they did the 2-stage treatment of the peroneal dislocation, missed peroneal dislocation, or old peroneal dislocation. What's your opinion about that? 2-stage treatment of the peroneal dislocation that was missed.
Thank you for your question. I think, in my opinion, when patient present to us after 3 or 4 weeks, 2-stage reconstruction of the wrist by applying an external fixator and lengthening in the fracture site and realigning of the corpus is the best option, because if operated on patient without this distraction, the fracture site may be so fragile and we cannot obtain any success. Thus, if the patient came to me after 3 weeks or 4 weeks, and I have doubt about the ability to reduce the fracture, I use external fixator for traction, and after about 10 days, I operated on patient and now reconstruct the fractures and ligamentous injury.
Thank you very much, Dr. Fatai. If there is anything that you panelists wanted to add, please go on. And my last question is from Kamran. Dr. Mozaffarian, one of the problems is differentiation of the ulnar impaction syndrome with the Kainbach, especially when it's the positive variants of the ulnar. Have you ever confronted with this problem that you cannot differentiate the ulnar impaction syndrome with the Kainbach?
Thank you very much. Yeah, there's always a problem differentiating these two different entities with different treatment plans. Even if the patient has not ulnar plus variants in a normal X-ray, we might get a dynamic X-ray with clenched fist in pronation to see what is the real ulnar variance in pronation and in clenched fist position. But the only clues that we have is that ulnar impaction syndrome, the patient has some other signs in clinical examinations, such as positive ulnar impaction test in different positions, such as in neutral or in supination or pronation. In one of these rotations, the patient might have pain because of the long ulna or at least ulnar styloid. Another important thing is on X-ray that we see the bony changes on the ulnar side of the lunate, which is the location of contact between distal ulna and lunate, while in Kainbach disease, we get the first sign of collapse and necrosis in the radial part of the proximal part of lunate, which is the effect of nutcracker effect. I didn't have time to talk about this nutcracker effect. And finally, in MRI, in Kainbach disease, we have to get hyposignal in T1 sequence, which is very important and can help us to differentiate it from ulnar impaction syndrome. That's the all points that I know. If I don't know if I answered your question.
No, it was very good. It was very good. Dr. Farzan,
Yes.
Welcome to our panel. what do you think about these questions, or if you have any comment in any of the subjects, we will be glad to hear it.
Well, Dr. Dianat asked a question about the immobilization of scaphoid fracture, whether to use short arm spica cast or short arm cast. I want to answer that in these cases, short arm cast suffices, and there is no need to use thumb spica cast or long short thumb spica cast or long thumb spica cast.
Okay, somebody preferred to include the term because they suggested it's make more stability of the fracture fragments, but there is somebody in the literature and there is some paper. It's not very different. Simple cast immobilization, or there is no different time of the union.
Thank you very much. There's a question from the participant, Dr. Iskandari, our colleague, has asked, what is the treatment of the chronic peroneal dislocation? Although you have some mention it, but if you have, Dr. Fatai, do you want to add to the previous point that you have said?
As you said, the peroneal fracture dislocation is a high energy trauma, and in all cases, the DJD is inevitable. Thus, I think in the very late cases, the best option is four-corner fusion, because capitate capital head also damaged. Thus, I use these techniques for all patients.
Thank you very much. I think we could start the interesting case that our colleagues has brought with themselves. I want to make the first case, which is mine. It's about the in pediatric groups. You know, acute peroneal dislocation is rare, but extremely rare in children. Until 2015, only 6 cases of peroneal dislocation in children has been mentioned. And if you go through these 6 cases, one of them is 16 years, so he's more or less adult. So in very young children, we do not see. I remember that in Rockwood second edition, the Wilkins has said, if anyone has experience with the peroneal dislocation in children, please report to me. I will include it in this book or the next edition. So it may happen in children, and the treatment could be very different. And the signs and symptoms are the swelling of the dorsum of the wrist, pain with the movement, slight finger flexion, and numbness of the radial 3 fingers. But these symptoms may disappear when you got the patient. It's somehow not permanent till you see the patient. The sign that you may have is the carpal tunnel syndrome because of the pressure of the lunate on the median nerve. 8th hand, carpal tunnel sign, which is like the Fallen test, but no compression of the other hand, Phelan test, and the Axner clasping sign, which is when you keep the fingers on the involved hand, you lock it, the patient is not able to flex the index. And the treatment is close reduction and PCP, but most of the time it may fail, and you had to do the open reduction and internal fixation with the pins, certainly, and sometimes you had to do the carpal tunnel release. This patient that I'm going to discuss belongs to 30 years ago when I was practicing in Bandar Abbas. You may follow the patient for a long period of time because of the degeneration that may happen, vascular necrosis, and instability of the wrist. This patient was a 5-year-old boy that suffered from the wrist trauma with fracture of the femur, the distal part of the femur, and deformity of the wrist and the hand. Patient was not able to extend the wrist, was not able to extend the finger, not in active and passive range of motion. When I examined the patient, there was some bony tuberance on the dorsum of the hand. It was firm and looked like it should be bone. So I had to open the wrist. As I, with transverse incision on the dorsum, as I put the incision, the scaphoid and the proximal row comes out. It was dislocated. The scaphoid was broken and lunate was dislocated dorsally. I have never seen, and I didn't see after this boy, I have never seen such a problem in children, because what I have learned was that the bone is weaker than the ligaments. So with a dorsal approach, transverse approach, I reduced the scaphoid and lunate and put several pins that you may see here. And after 1 year, I had follow up the patient. As you may see, there is a slight limitation of the dorsiflexion, but the voriflexion was good. And I haven't seen the patient then after, but I have known that he's doing a farmer. He's living in the Bashagad, which is a primitive kind of life. And they are very, they live like the Stone Age. I don't know if anything happened to his wrist, but I have heard that he's a farmer in Bashagad and he's married. So I think because I didn't have the X-rays, I didn't report this case. But as you may see, it's very astonishing that it may happen. The peroneal dislocation may happen in children. The second case is the case of Dr. Farzan. Would you mind, Dr. Farzan, to talk about your case? Dr. Farzan, do you hear me?
Yes, yes. In the name of God. Hello, everybody. I'm Dr. Farzan from Zanjan University, and I thank Dr. Lahiji who gave me the opportunity to present my case. The patient is a 31-year-old man. He is manual worker. He has trauma to his right wrist injury during house building 9 months ago with this device, and he suffered wrist pain and deformity. Here is the CT scans and radiographies of the radiographies of the patient. In PA view, you can see the shape of the ulna, and also you can see an old non-union of styloid of ulna. Unfortunately, the patient didn't give any history of previous trauma. And also in lateral X-ray, you can see the shape of lunate and also some flecks of osteochondral bone. Here's the axial view of the CT scan. Here's the lunate and also the fleck of the bone. And also in coronal plan, you can see the empty place of lunate. In sagittal plane, you can see the shape of lunate. And also in three-dimensional CT scan, you can see the displacement of lunate. So the diagnosis of the patient is volar lunate dislocation, lesser arc injury, stage 4 Mayfield. Here are the radiographies of the patient, and here are the radiography for education. As you see in PA view, the rectangular shape or trapezoidal shape of lunate has changed to triangular, which is called piece of pie. Dr. Fatai talked about it. And also in lateral view, the lunate has rotated almost 90 degrees, and we call it spilled teacup sign. The surgeon decided to reduce it as an emergency. He tried to redislocate, reduce the capital lunate by Tavernier method. As you know, in Tavernier method, the surgeon puts his thumb against lunate and then applies axial traction to the metacarpal, and from hyperextension goes to flexion. And you may hear an audible clunk when the capitate reduces in the lunate. Now, after reduction, the wrist goes from flexion to neutral or slightly extension. No signs and symptoms of median nerve injury were noted in this case. The reduction was unsuccessful and unstable. The surgeon decided to go with the operation. The surgeon first chose dorsal approach, but was not succeeded to reduce the dislocation. So he added volar approach. He reduced the lunate, fixed it, and also repaired the scapholunate and tibio-lunate ligament as far as possible with simple suturing the substances of the ligaments. Here you can see the fixation, one pin from scaphoid to capitate, one pin from scaphoid to lunate, and one pin from triquetrum to the lunate. Then he immobilized the wrist with a splint for 2 weeks, and after removing sutures, immobilized the wrist with a thumb spical cast for additional 6 weeks. And after 8 weeks of surgery, he removed the cast and pins. Now here are the radiographies. You can see the lunate is here. The gyrolized line is okay, and everything seems okay. The surgeon advised physiotherapy, but the patient refused it because of financial problems. And here is the results after 9 months after operation. As you can see, right wrist has limitation of flexion, limitation of extension, but the supination and pronations are good. The patient also suffers from little pain during work. Now, the question is that what approach was the best for patient? Dorsal, volar, or double? And what is the next step? As you know, in volar approach, we can easily approach the lunate, decompress the median nerve, repair the volar ligaments, the volar scapholunate, volar triquetral-lunate, and also radial lunate ligaments, repair the extrinsic ligaments. But in dorsal approach, you can repair important dorsal radial lunate ligament, dorsal triquetral-lunate ligament, but the disadvantage is that the risk of AVN increases. And in double approach, you can easily repair all the ligaments, fix all the fractures, and reduce the dislocation. But adhesion is problem, and we have more problem of limitation of range of motion and also increase in the risk of AVN. So I thank you for your attention, and I am ready to hear your answers to these questions. What approach was the best for the patient? And what is the next step for the patient? If any volunteer can talk about the approaches.
Dr. Fateh, would you like to answer these questions?
I think the best approach for the treatment of the peroneal fracture dislocation or peroneal dislocation, especially in the presence of the CTS or impairment, sign of impairment in median nerve, is combined volar and dorsal approaches. Because through volar approach, we can release the carpal tunnel and also reduce the lunate in lunate fossa and repair the mid-carpal ligaments. And through dorsal approach, we can repair the important ligament, scaphoid ligament, and other structures that may be injured through trauma.
Dr. Dianat, what is your opinion? Can you help us? Do you routinely use a double approach for the lunate dislocation?
I think the first incision is the volar aspect of the wrist, because we have to release the median nerve and then reduce the lunate. And we can moving the wrist, if it is stable, we can only fix the carpal bones with the pins and have a time for ligamentous repair. But it is unstable if we on the volar stage. If it is unstable, we have to make a dorsal incision for repair of the others ligaments.
Thank you, Dr. Dianat. And is there anybody else who can guide us?
Dr. Mozaffarian, would you like to answer the question of Dr. Farzad? What is the best approach, dorsal or volar or both? And the second part, what's the next step?
Yes, I may be old school surgeon, I don't know, but if the patient is presented in acute stage, I mean in few days to us, which is not very common in our country, we usually see the patient after a couple of weeks. But if we see the patient after a few days, and if we don't have any sign of median nerve compression, I prefer to start with dorsal approach, I mean the posterior approach, because it gets me enough exposure for reduction and to remove the interposed soft tissue such as capsule, and then do the fixation adequately and check the position of the different carpal bones. But if the reduction is not possible, which is very common when the patient comes in later stages after a few weeks, it might be not possible to reduce the lunate from just one single dorsal approach. Or if we have median nerve paresthesia, I go to add the second carpal tunnel extended approach in the volar side. Regarding the second question, because I think that according to literature, it's not essential to repair the volar ligaments. But if we use the volar approach, we have to repair the long radial lunate ligament. Regarding the second question, I think I didn't understand the second question completely, but I think we have, yeah.
The question is that the patient has restriction of motion and also little pain during work. How do you address the problem? Conservative, going to operation, what do you propose to the patient?
Yes, I think I would say that I go with conservative treatment and continue more aggressive rehabilitation programs. I don't know if any further surgical approach and intervention can help the patient with the range of motion. But if one important thing, if we see sclerosis of lunate, which is sometimes seen after perilunate dislocation, we don't have to go ahead to do something with this for this ischemia, which you know that it is temporary and it will be resolved spontaneously.
Thank you, all my colleagues. In my idea, if we have signs and symptoms of CTS, it's better to first approach the patient from volar approach. In some articles, especially the Indian surgeon says that only volar approach suffices. They decompress the median nerve and reduce the lunate and also repair the volar ligaments, and they do not touch the dorsal ligaments, and they have got good results with the volar approach. But in my idea, if we don't have any signs of median nerve compression, it is better to approach from dorsal, repair or fix the important dorsal radiolunate ligament, and also trichotillunate ligament. And if we were not able to reduce these reduction or fix the fractures, we can apply another volar approach. Double approach has risk of increased risk of AVN and also limitation of range of motion, and I do not recommend to use it routinely. I add another approach, volar or dorsal, to my first approach when it was necessary. And also for the patient, I try to rehabilitate the patient, give him the support, and in case of intolerable pain, and also DJD, I propose him wrist arthrodesis. Thank you.
Thank you, Dr. Farzan, but I think till the stage 3, which is somehow most of the time it's stage 3, the volar ligaments are intact most of the time. So I still think that the dorsal approach may be better because the strength of the scapholunate is dorsally and not the volary. So
but this case was stage 4.
Oh, yeah. The third case belongs, I think, to Dr. Dianat, which is a very interesting. Could you maybe not. 2 seconds. Escape. No, it's sorry, it's yeah. Dr. Dianat, would you mind to describe your case? I will change the slide. If you just say the next slide, I will do it.
Okay, this is a 55 years old man, right-handed, and he's a house worker labor from falling down from 2-meter height 2 months ago. The first day he referred to the bone setter, and they manipulated that case, and he I cannot categorize this kind of the fracture dislocation. So this is the first time I faced with this kind of the fracture dislocation. Usually, basically, the lunate dislocated in the volar side and a scaphoid in the dorsal, but this is reverse. The lunate is dislocated in the dorsal of the wrist, and the scaphoid in the dislocated on the volar side. After 2 months, he referred from the other city around the Tehran. We decided to open reduction because there is no any place for closed reduction after 2 months. First, we try to approach with the dorsal incision. As the Dr. Lahiji told before, the lunate was under the skin and push out when we made the incision on the dorsal side. So the lunate was totally sclerotic and devascular and a vascular sign. So we try to approach to the, this is the, we try to approach to the volar side because the scaphoid was in the volar side. Try to remove that because that was a sclerotic bone, and with the change of the cartilage. So we decided to make a proximal recarpectomy and fix with the 2 pins. Unfortunately, there is no any the follow-up of the patient because he couldn't return back to my clinic, and only my file is the post-op fixation like this.
Thank you very much, Mr. It was an interesting case. I have seen one article in literature that the scaphoid was done in the forearm. A part of the scaphoid was done in the forearm. You know, the permanent dislocation, each one of them has a different story and individualize. You should, when you are going to treat them, you should individualize the problem. They are not always the same. For example, in transscaphoid, transcapitate, most of the time, the proximal part of the capitate has rotate 180 degrees. And this is a problem to distinguish it and to return it back to its own place. So I do not think that the peroneal dislocation, in my personal experience, closed reduction, I believe, has no place for it because you must repair the scapholunate. So with closed reduction, it may not be possible. So the last case would be the case of Dr. Ahangar. Dr. Ahangar, I know you have a harsh voice and because of Corona, but no problem. We do not miss your case. Would you mind to describe it for us?
Yes.
And you just say, change the slide. I will do it for you.
Yes. This case was 18 years boy. The second slide, please. Second slide. The next. Yes, the 18 years boxer boy suffered from motor vehicle accident 8 weeks before referring to me with the left wrist pain and with the 6 weeks casting. Please next. These are the range of motion of the left wrist, maybe 20 degree total arc of range of motion with pain. The next, please. These are the radiographies. As you show, we can see a line in the AP radiography in the proximal pole, and the piece of bone, if you show Professor Lahiji here, volar, here, yes. This is a proximal scaphoid fracture dislocation. The proximal fragment dislocated from the scaphoid fossa to volar site. 8 weeks after injury, we faced with the patient. The next, please. And this is CT scan. This is a fragment. As you know, we talk about this patient in the Iranian Hand Association, and I used my mentors and the hand experts' opinions to treat the patient. Next, please. This is MRI. No significant dysvascularity I see in these images. Next, please. I found only 10 reported similar cases in the literature. A couple of treatments from proximal fragment excision to fixation with the bone grafts, without bone grafts, and other options have been done. Please. Next, please. First, I try to reduce the fragment from dorsal side, but unfortunately I couldn't do that. And I did a small volar incision and pushed the head back to the scaphoid fossa. Next, please. And because the more important ligament in the scapula is dorsal scapholunate ligament, I try to augment the ligament with the Viega technique, with the dorsal intercarpal ligament and dorsal capsule. Next, please. This is my these are not my pictures. These pictures from wrist book. The next, like this. I did like this. Next, please. Like the next, please. And I put 2 key wires to lessen the rotational forces to reconstruct ligaments from scaphocapitate and scapholunate, and fix the fragment with the Herpert screw. Next, please. This is the scars of the incision, dorsal side and volar side. Next. This is the result after 18 months after surgery, no pain. The next, please. Next. This is the force of the both wrists are equal. It was good until 1 year ago. They didn't come back to me. Next, please. This is the final radiography. we achieve a good union, but the scapholunate space is wider than normal, I see. And I called him a couple of days. He's still working, he's still boxing. He have not pain. But my question is it any need to reconstruct the ligament, Professor Lahiji? Professor Lahiji?
Yeah. I heard it. Let me see. You know, in the boxer, I have seen one of the national champions that he has been referred to me because of some little pain during the boxing. When I see the X-ray, I was just astonished because if I show you the X-ray of this patient, it was the scapholunate was so wide and degeneration. But the patient was going to go for the international competition. So in the boxer, I think it's just the stretching. And they do it well. I don't know. In my experience with 2-3 cases during these 30 years, I always see that the scapholunate is stretched in boxers. This is the only thing that
I see.
I don't know if anybody else.
Maybe the normal variant in boxers.
Yeah, perhaps.
Yeah, thank you. Thank you.
Okay, it's 10 o'clock and we are finished. I should thanks Dr. Tabakkuri because I heard him a lot of times. I didn't answer the phone. I didn't mention the messages because I had a personal problems. I wish that you forgive me. But thank you very much for trust us to talk about this very complicated part of the body. Thank you very much. I am, on behalf of all my panelists, I thank you very much for your kind invitation.
Thank you very much, Professor Lahiji, and very good session of the hand. Now we are going to watch the closing video clip, please.